And we are live. How y'all doing? And welcome to Disrupting Kidney Care Round 6. This is where we bring you the heavyweights of kidney care. And this one has been especially successful. We've had over 550 attendees for this particular webinar. I am Dr. Qasim Butt with Your Kidneys, Your Health. I'm an interventional nephrologist and clinical nephrologist of many years. I still practice medicine and get to work with innovative technology companies like Leo and DeLorean AI. So I'm on that route to more health tech, but I still got love for the clinical aspect of medicine. Right now in that comment section, please tell me who you are. What's your relationship to kidney care? Where you're from? Are you a doctor? Are you a nurse? Are you an executive? Are you a patient? And also feel free to leave some comments in the comment section for our guests throughout the webinar. At the end, we're going to ask them all the questions you have. Disrupting Kidney Care is the place where we discuss trends in the market, including home dialysis, new technologies, the patient experience. But today we're covering a crowd favorite, a topic that's a crowd favorite, value-based care. And we're doing a 2024 update of value-based care. Excited for this one because we got 3 different doctors, 3 different organizations, and 3 different ways of approaching value-based care. So where did it all start? How did it all start, right? Well, it started in 2019. Well, in 2019, President Trump had signed the executive order on kidney health. It was actually brought to us by his Secretary of Health, Alex Azar, whose father was a dialysis patient and involved in kidney care. So he wanted to improve it. I went ahead and read that executive order. I would not recommend you doing that. Reading an executive order is kind of boring, but I wound up doing several presentations on it. But the 3 goals of the executive order are, by 2025, have 80% of new end-stage kidney disease diagnoses start dialysis at home or get a preemptive transplant. By 2030, reduce the incidence of end-stage kidney disease by 25%. And by 2030, double the numbers of kidneys available for transplant. Now, in order to do that, you have to have incentive structures, right? You have to actually change the way you pay people. And how did they come up with that? What did they come up with to do that? Well, they came up with new value-based kidney disease payment models. Essentially, CMS came up with a alphabet soup of new kidney care models for you to learn, okay? We had the ESRD treatment choices model, the ETC model, which is actually a compulsory model that certain practices were selected for. We had the kidney care first model, which is the KCF, which a practice can actually negotiate directly into the payment models. Then you have the comprehensive kidney care contracting models. This is a little bit more in-depth. Other organizations can participate, dialysis companies, transplant centers, and you create something called a kidney care entity, which is like a governing board over that value-based model. Then, of course, before I get to the Medicare Advantage, the thing is about these value-based models, they oftentimes can be very difficult to navigate for a physician practice, right? They oftentimes don't have the analytics, they don't have the logistical support to actually implement the aspects of value-based care. And that's where you had all these organizations come up that are value-based centric, that actually partner with you and partner with CMS to actually create that bridge between the two and help implement value-based care. Now, they can do it through these models like the CKCC, but some of them actually contract directly with Medicare Advantage. And we have 3 of those major players here today. Now, the clinical metrics to follow, these are the things. So we have these incentive structures, but what are we actually incentivizing, right? Well, we need these clinical metrics. I call them KPIs, kidney performance indicators. Just kidding. What are those, right? What are we trying to incentivize? Well, one of the things we're trying to incentivize is optimal starts on dialysis. Optimal starts means someone is prepped for dialysis properly, initiates dialysis in the outpatient. What we're trying to do is actually disincentivize crashing into dialysis. Crashing into dialysis is an experience 20 to 40% of our patients have, but they literally crash into an ER and are told they need dialysis. They have a catheter put in their neck, they still have an extensive hospitalization, and it's a traumatic psychological experience for a lot of people to be introduced to the modality in that way. We want to increase home dialysis rates, right? Home dialysis, the market penetration is about 10 to 15%. We want to increase the market penetration because home dialysis has been shown to have better outcomes and longer lifespans for these patients and give them that autonomy they've always wanted. We want to increase referrals for kidney transplants because kidney transplant people live longer and cost Medicare less. Okay. We want that early detection of kidney disease as well, because I think a lot of us nephrologists, we're kind of sick of getting those late stage kidney disease patients, stage 4, stage 5, where really we can't really do much for them, but introduce them to aspects of dialysis. And lastly, and I think most importantly, we want to slow the progression of chronic kidney disease. That's what we want to do. And what you start to realize is by the time you make it to stage 5 or end stage kidney disease, you have an expensive disease process. So the best approach is to go upstream, stage 3A or 3B, slow down the progression of kidney disease and prevent them from ever going on dialysis in the first place. Now, the stuff we're going to be going over is kind of complex, and it's going to be a good learning experience. So I have arranged CMEs are available. If you want for free, you just need to go to my website, yourkidneysyourhealth.com, and you can actually get a CME for free for doing this. Also, you can see my more in-depth lectures on the CMS models as well. So I think we're ready to start. So let's see here. Let's bring up our first guest today. Okay, let's see here. Our first guest is, let's see here. First up, we have a seasoned nephrologist who has practiced transplant nephrology and managed a successful practice. He was part of the founding leadership at Interwell and went through one of the biggest mergers in value-based care with Cricket Health. From North Carolina, at guard, 6'6". All right, that's Michael Jordan. From North Carolina, the Chief Medical Officer of Interwell Health. Please welcome Dr. George Hart. George, how's it going?
It is good, and I'm only 6'5", not 6'6".
Oh, is that right? Is that right?
There.
I think all men want to be introduced like Michael Jordan at some point in their lives, so I just wanted to give that to you.
Well, I appreciate it. It was good. It was good for me. I was glad you didn't say I was bachelor number 1. So
that would not be appropriate. That would not be appropriate, sir. So tell us a little bit about yourself, George.
Sure. A native North Carolina resident. Came back to North Carolina and practiced nephrology from 1992 to about a year ago. Part of a great practice in Charlotte, and got to do all the things that I wanted to do clinically, and kind of found that despite being in a great practice, that the things that we wanted to get accomplished, we weren't able to do in a fee-for-service world. So we kind of leaned in early to value-based care, part of the ESCO programs, and kind of the more I learned about it, the more I thought, okay, this is really the way to go. And when this opportunity at Interwell came up, it was just too good to pass on. My wife thought I was crazy, but it's turned out to be, another great adventure. And I'm excited to be here and get a chance to talk about all this.
Awesome. And I don't think most women think they have sane husbands anyway. So you're okay, I think, right? So, exactly. All right. Next up, we have a disrupting kidney care repeat offender, a man who's at the founding of his company as well. He's implementing innovative approaches like telehealth to kidney care. Hailing from Louisiana, this man just told me he was so tired because he just got over Mardi Gras. And you know what they say, what happens in the French Quarter stays in the French Quarter. Please welcome the Chief Medical Officer of Monogram Health, Dr. Shaminder Gupta. How's it going, Shami?
Yeah, hi, Qasim. Good afternoon. Hey, George. Thank you for the invitation today.
All right. Tell us about you. I know you've been on before.
Yeah. So thank you for inviting me back. I guess it was either really good or really bad the first time, but thank you for inviting me back. But briefly about I'm a nephrologist, born and raised in Louisiana. I'm a proud member of the Who Dat Nation, Saints all the way in the dome. So that's my hobby I like to do. But I've been practicing value-based care even accidentally since I finished my training in 2004. I was actively involved in the charity hospital system of Louisiana, where I led a lot of disease initiatives in CKD and hypertension, and found myself building a home dialysis practice in rural Louisiana, kind of just winging it, so to speak, from 2008 until 2019, achieving high levels of home dialysis in an underserved population. And then this interesting thing called VBC came along, which, rewarded outcomes and not just fee for service. But in the charity system, you tend to work on a value-based system in general because you're not RVU based. So very fortunate to have met the company as they launched in a disease-rich area, New Orleans, Southeast, Gulf states. And that's those skills that I had learned as a clinician really applied themselves to our model of care, which again focuses on all those KPIs you went through in your introduction. So really excited to be here today and share some of the ways we're innovating and look forward to the discussion with my colleagues and yourself.
Awesome. Okay, next up, let's go for it. I got a woman on next who's been practicing value-based care initiatives before value-based care was even a thing. She has a foresight to know the importance of optimal start for her patients before CMS did. A woman who now helps the primary care doctor she works with best manage their CKD patients better. Please welcome the National Director of Kidney Care for ChenMed, or as I like to call it, a Jersey girl of kidneys, Dr. Virginia Irwin-Scott. How's it going, Virginia?
Thank you. And
I told you I was going to call you that. I told you I was going to call you that.
It's all good. I am a Jersey girl. Thank you so much for having me here today and to join this amazing panel. I have been blessed in this last year. My introduction to ChenMed was your very first Disrupting Kidney Care when my predecessor, Dr. Kata, was speaking. Shortly thereafter, I had gotten a LinkedIn reach out, would you be interested in considering this job, which is how I ended up here. And it's because of, listening to him speak and wanting to learn more about how he was influencing primary care and, to improve outcomes for these patients is why I'm here today.
Awesome.
So I was a South Jersey practicing nephrologist for many years. I had a partner. We started a practice back in 2004, 2003, where we did only outpatient nephrology. So back in the day, people thought we were crazy doing only outpatient.
And this was in the 2000s, right? Early 2000s,
correct.
Right?
And we did CKD management. It was before CKD was even a real term. It was, we called our place Center for Kidney Disease, and we took all the CKD you can get, Gmail accounts and everything, way back when. And we optimally started patients. We didn't have a hospital-based practice, so it
that's
was
interesting because when I started in 2010, I remember we by standard started them in the hospital. Like we would always, irrespective if they had access or not, we would start them in the hospital. So
I had to convince Fresenius that it was a good thing for me to start patients sitting in a chair and DaVita and everybody else. And really were successful. My, outpatient start rate was well over 90%. Patients had accesses. They were listed for transplant. It was really, for years, I thought that's how I was supposed to be practicing as a nephrologist.
Wow.
And as many of the VBCs came to me before I left my previous organization, I was like, well, how are you going to save me money? Because I'm already doing all this. And it's really, translating it now into the primary care aspect and really working with primary care providers to coordinate.
Well, let's get into that. Let's get into that. So right now we have three different approaches. We really have three different approaches to value-based care represented here by your organizations, right? So let me ask each one of you to explain your organization's approach and philosophy on its actual implementation. So Virginia, you're already talking, so go for it.
So again, we're a primary-based organization that is Medicare Advantage only. We do have some dual eligibles as well, 55, 65 and over for the most part for our patient population. And, primary care is a center touch point for all of those patients. We identify patients with chronic kidney disease and, you're talking 60, 70, 80,000 patients in our organization who have chronic kidney disease. So really working with primary care in stage 3, A and B, helping them to identify patients to slow the progression of chronic kidney disease is really a big part of my job. Doing case reviews with them, talking to them, educating them, working on pathways with them. But down further in that stage 4 and 5, I'm blessed to have an amazing ChenK kidney team of nurses who actually are the concierge managers for those patients. They interact with the primary care.
So are you guys referring to nephrologists as well, or are you kind of keeping it on?
Oh, yeah.
You do.
So, when that patient starts getting into stage 4, I need to start sharing that care with a nephrologist in the market so that we can coordinate, that downhill, what's going to happen in the future to try to work towards that optimal start.
And it's interesting you bring this up because I think oftentimes good kidney care is actually really good primary care, right? And so because we've all done that. George, you speak to what you're doing, man. I know you guys are doing big things at Interwell. So
yeah. So I think it's great to hear Virginia, how you guys have set things up. In 2019, Qasim, you were talking about the Advancing American Kidney Care Act, and I think that was a prompt for Interwell's creation at the time. And look, we started from the very beginning assuming and with the premise that how would you ever take care of people with kidney failure and not involve and include nephrologists? So from the very beginning, our approach was to partner with some of the leading nephrology practices across the country. And from 2020 to now, we've been able to partner with over 1,800 nephrologists nationwide. Even better, 1,200 of those nephrologists were so committed and so interested in what we were doing that they chose to invest some of their hard-earned money in Interwell. So we have a large network of investors, and we think that's fundamental to how we solve the problems with both CKD and ESKD. It's no secret we have a longstanding, deep partnership with Fresenius, and I think that was important as we started in late stage CKD, but first even in ESKD, because there was so much high cost and opportunities there. We are expanding to not just Medicare Advantage, but are participating in the CMMI models. We have almost 10 years now of value-based care experience when you go back to the legacy organization.
Yeah.
Yeah. So, we have battle scars that we've all, learned during this process. But we continue to believe that nephrologists will be the cornerstone of how we try and solve some of this. Our motto and our mantra is that we want to come alongside nephrologists, work with them, augment and amplify what they're trying to do. And we think that that's the way.
And George, that's the thing with the CKCC models. We're about to get into those too.
Yeah.
But it put the nephrologist at the center, the nephrology practice at the center of the heart of what the models do.
Yeah,
right?
when you transition from the ESCO models into the CKCC models, you went from the dialysis companies as a source of attribution to the nephrologist as a source of attribution. So you also expanded to include CKD as well as ESKD and transplant. So, it's all morphing into a direction that I think we all would agree is the right direction.
Absolutely. And Shami, go for it, man. Go for it.
Yeah, thanks, Qasim. For us, we've evolved over time. Our mission really is what differentiates us a little bit is we take full risk on about 100,000 Medicare Advantage dual eligible lives across the country in 35 states. We started as an organization that partnered and worked with nephrologists to drive outcomes, very similar to what you've heard already. And we've learned over time that a lot of these patients that we're at risk for, these Medicare Advantage lives, and we go full risk, Part A, Part B, no matter what they go in the hospital for, don't have doctors or providers because of their rural nature or the fact that they just can't get to those physicians. So we have evolved into an organization that not only supports their journey with their PCP, nephrologists, and subspecialists, but also provides care when necessary in an urgent fashion or longitudinally for those members that don't have care.
Like in the rural markets, right? That's what you're saying?
Yes.
Like in those rural markets in particular. Is that
particular rural markets. And occasionally we find an urban patient who just can't get to their doctor, has complex medical needs that are better served at home. And in those situations, we fill the gaps and take care of those patients while they get back and forth between their regular doctors that they see. But we are a big into high value clinical interventions. At the time of needing those patients, we deploy nurses, nurse practitioners, social workers, all the cadre of support to these patients' homes, and communicate that information back to the relevant PCPs and subspecialists, all with the hopes of decreasing utilization and optimizing outcomes. And one other piece, Qasim, is that we firmly believe that end-stage kidney disease, should be treated with transplant and dialysis when appropriate, home first. But we also have a heavy emphasis on conservative kidney management when appropriate. So those patients that may not thrive on dialysis, how do we soft landing them through their nephrologist onto these pathways of conservative management through medications and symptom-based care?
No, and that's something that I think that is something that's really unique. Not unique, but something you guys do emphasize. But how is the telehealth model working for you guys? I know you guys incorporate that as well too, right?
We do, but we still focus on an in-home model first. Our patients that we take care of, they're all over the country, but we deploy patients care to them based on their CKD stage. So just very briefly, upstream, just like we do in an office 3, 4, 6 months as they get closer to end-stage kidney disease more often, post-hospital discharge. But the majority of visits are still done in home, whether it be by a nurse practitioner, social worker, dietitian, supported centrally by a physician team, as you alluded to. And then we customize that approach, whether it's behavioral health, SDOH, whether it's clinical, whether it's both, They have a nephrologist, they don't have a nephrologist. How do we work together for that common KPI outcome you described, a planned start?
The thing is, even with telehealth, because I think we've all done telehealth to some degree, I think those physical touch points are still crucial for these patients, especially these complex patients. I don't think a screen is enough sometimes. So I like the idea that you guys do those home visits as well. Yeah. Now, just going into it, I know you guys kind of mentioned some of it. It looks like some of y'all are doing more CKCC, some of you guys are doing MA plans. You know, and let me ask you this: are your organizations going full risk on these patients for the total cost of care of these patients? I know you some commented to some of it. And by the way, to those of you who don't understand what that means, total cost of care there means these organizations are completely responsible for the total cost of care of these patients, and so they benefit if the patient does better. So go for it, Virginia.
I can start with that. So we are a full 100% downside at risk model. You know, and I like to explain it when I give, you know, lectures.
Upside and downside, right?
Yes. You know, you get your bucket at the beginning of the year, and as the, you know, the hole in the bucket is dripping out, you know, depending on the hospitalizations, you know, the total cost of care, it's coming out of that bucket. And then again, you know, making sure that these patients are being correctly identified, that the social determinants of health, making sure that the coding is correct in terms of, are we getting the funding from CMS for an ESRD patient? Like, all of that is crucial to making sure that you're getting the proper funding, but then the management side on the other side with, you know, making sure that your primary care providers are engaged with these high risk patients and your nurses are involved and the social workers, you know, everybody has to be all hands on deck to really manage these patients well.
George, I know you commented both, right? So you guys are doing a little bit of both, right?
Well, we are. We currently participate in 24 KCEs, both global and professional, which means that there are different risk tolerances between those KCEs, or risk appetites maybe. And then we also participate with MA and even some Medicaid. I think what you're going to hear from me and Virginia or Shami is a consistent approach, which is, you know, we're all looking for ways to solve and execute on disease management and look at how to manage comorbid conditions. I think we've all recognized that fee-for-service failed in so many ways because there were gaps between physician visits where we think we've put together a great care plan, and it turns out the patient was overwhelmed. They didn't understand what we were saying.
It could never be implemented, right?
It could never be implemented.
Yeah.
So our strategies are similar in that, you know, you have care navigation, you have maximizing education, bringing in social workers, dietitians, pharmacists on occasion, you know, whatever the resources are that need to be brought to bear. You know, I think we're all trying to do that. I think the difference for us in the CMMI models is the deep relationship you have with physician groups in these markets. Where the physician groups are now able to actually gain traction and operational efficiency. So they're able to create some of their own workflows in ways that allow them to better deliver care in a value-based fashion.
So you're not bringing the workflow or the clinical care pathways to them. You're letting them decide them for themselves. Is that what you're saying? Or a little bit of both, I would say.
So, you know, we might have 80 different practices in 80 different markets. So it's not necessarily one size fits all. Some of the fundamentals are the same.
Yeah.
In certain markets, we will have nurse resources actually embedded in the practice. In other markets, it's ongoing, you know, telephonic support.
And Shami, you want to go ahead? I know you
said we specifically are in the MA space for the most part. But the nice thing, to George's point, a lot of these practices have evolved to where they're doing value-based care across their book of business. And we bring to the table an opportunity to still maximize opportunities in that MA population. To Virginia's point, you know, increasing appropriate coding, getting what you're entitled to for that complexity of illness, but then helping that practice through our deployment of an in-home team, working with them to kind of nip things in the bud before they get out of control. We're full risk, and we have worked with nephrologists for that patient population with incentives to help them get those results that we desire clinically for the patient, whether that be an outpatient start, a completed transplant, and even have worked with practices on conservative kidney pathways. So, you know, currently there's no MCP for for a conservative pathway, but we want our nephrologists to have the flexibility to be able to take care of patients that way with our support, centrally or peripherally, to drive those outcomes in the right basket. So we have our own guidelines we discuss with practices, but to George's point, we work with them and on how they do their own business and try to integrate into their workflows with those teams.
Like I went to ASN recently, like in Philly, the one in 2023. And that was actually the first time I've actually gone with an industry badge, which was kind of weird. So I was on the other side for once. But I got to talk to some nephrologists, and a lot of them have apprehensions about none of you guys were mentioned in particular, but like they're apprehensive about what's going on. They're apprehensive. Hey, I've talked to this value-based company. I'm not sure what they're doing for me. So, but what is your business response when you go to these practices and you talk to them? Has it been overwhelmingly positive? Has it been overwhelmingly inquisitive, or has it been kind of like skeptical? What do you?
I'll start with that one, just because I've been doing this for 5 years now for Monogram. And at the beginning, it was a lot of apprehension, a lot of what is this? How are you going to help me? You're going to mess up my day. It's going to be complicated. I'm already so busy. But as the education around has evolved, it's become easier and easier to discuss with practices how they can do this better for their different populations of patients and kind of work with them and not create tension for them. So I've been pleasantly surprised over the last 4 or 5 years, the greater acceptance of what we're bringing to the table and the understanding the financial opportunity that the practices have when these things are done. When you get a call on Friday afternoon and you don't say go to ER, but let's work with the team to get a planned dialysis start over the weekend or on Monday, helping them. And there's a financial reward for doing that. In addition to good clinical outcomes, it's a lot easier to sell now. So,
yeah. And we talked about that, Shami, like sometimes the communication is so crucial. Like for a physician, like if I wanted to start someone on the weekend, it's difficult sometimes, right? Yeah, it's difficult to coordinate. The weekends are off. Like, sometimes it's so weird. Like I want to get the case manager at 5 o'clock on Friday. It's going to be very difficult, right?
Right.
But it looks like you guys kind of facilitate that. Is that
yes,
right?
Exactly. So.
Cool. And then, George, go ahead. Tell me what your response has been. I know you've probably seen it for a while now, so.
Yeah, I mean, I think we all have to kind of take a step back and just remember, value-based care is hard. And we're trying to roll this out at a time that nephrology practices are, facing some of the burnout issues that have come on the heels of COVID, small business concerns, they face the same challenges. So, and we also have to remember that even in the practices that are embracing VBC in a large way, the majority of their workflow and what they do is fee for service. So we can't disrupt their lifeline. And what we try to do is to come in and, not create workflows that disrupt the rest of their fee for service world, but add value by creating safety nets and working with them in ways that improves workflows. One of the ways that we're really excited about being able to do that is that Interwell owns Acumen, which is the leading nephrology EHR in the country. About 2/3 of our network now are on Acumen, and by the end of 24, about 75% of our network will be on Acumen.
Mm-hmm. So what that's in the CKD clinic space, though, the Acumen, is that correct?
It is.
That's not right. Not in the dialysis unit itself.
Well, it actually does roll over into the dialysis unit, and that's the beauty of Acumen. It's built on an Epic chassis, so you have this interconnectivity, and I think it really sort of comes close to achieving this utopian goal of being able to create connectivity and break down the fragmented care that we all kind of are trying to correct.
And that's something I've really realized, like going from private practice to I'm at university, UT Health San Antonio and a university hospital where we all have Epic, and it's an integrated health system, right? So when I see a patient in a clinic, I can see their cardiology note, their primary care note. I can see their social worker issues. I can see the hospital admission, what happened in the hospital. And that integration to me, like, adds so much value to that appointment, right? Like all of a sudden I know exactly what's going on as opposed to waiting from the fax from Methodist Hospital over there, or what I'm saying, that kind of that siloed nature of our information in healthcare.
Well, I was in Dayton, Ohio last night at a meeting, and a primary care doctor on Epic was able to tell me that he could see the dialysis notes.
Oh, wow.
So that sort of interconnectivity, goes to address what we've all been talking about here is how do we improve the communication, the comorbid management that you have to have in order to be successful for these patients.
Absolutely. Virginia, you want to take it for what were we talking about? I think we kind of lost
relationships with nephrologists.
Yeah. Yes.
From our side, we have different models. We do have some contracted nephrologists who actually come into our clinics and see the patients in the clinic. And a lot of it is, discussions with, some of the providers, the nephrologists in the region who have an interest in doing so. For the most part, they do have some background history in value-based care. They understand what they're getting into by doing it. So that arrangement has been good. For the most part, when we send patients out, it's a fee-for-service arrangement, right? They're billing fee-for-service to see our patients. What I think is interesting is as I look around and build our provider network for nephrologists is I will often try to align with, nephrologists who are either in one of the CKCCs or KCE because my feeling is even though those are Medicare patients, they kind of understand what the goal is at the end of the day.
Yeah.
And we can try to control the cost of care that way.
It's really just a change in physician behavior and clinical practice. That's what we're trying to implement here, right?
100%.
And so it's like almost you have to change of a mindset. And I think CMS is just dangling dollars in a different way to make you do it, right? So, but in generally, like with these contracts, I think some of the things is how are you rewarding doctors? Are there kind of bonuses for good results? Is that how it's working for you guys, or how's that work out? And you can talk in generalities, but go ahead.
Yeah, for us, not so much the reward system as much as, them growing a future dialysis population, 5-10 years out. And I think it's just, creating that relationship with a primary care provider who can provide primary care to the base of the patients. And then, they have that patient long-term for nephrology care.
Yeah. We have different layers, Qasim, of how we engage with the practices. Some are, we know it's a time squeeze for them. So we have some opportunity just for PM types incentives for engaging with us and just talking to us. We have high risk rounds with some practices to discuss high risk patients that generates good outcomes. We have direct incentive payments for certain activities, like you mentioned in your intro, with all those KPIs that we know the patient, the practice can struggle with at times, but us at Monogram will come in and support that journey. So how to get that access placed and mature. And while you're doing your thing as a nephrologist, we're in the background helping.
Your reward is making your life easier. Is that what you're saying?
Well, we're trying to recognize how difficult it is to be a nephrologist and how to have a planned start and how to complete a transplant, that we can do all the things right from our end, but we don't do the transplant. We don't put the fistula in. We don't do all those things that are hard to do. So let your VBC partner help you do that, generate a good outcome that's best for the patient, but also recognizes and acknowledges your time and energy you've spent and rewards you financially. So we've had a lot of good response from big practices and markets that are already participating in CKCC for their Medicare patients. And now we bring to the table MA type incentive programs that they really are receptive to.
And that's interesting because I remember like in my old practice when it was a pretty relevant practice. So I was not practicing value-based care, but some of the metrics like, optimal starts, keep them out of the hospital, all that kind of stuff. We never got rewarded. You see what I'm saying? So, and so now you're allowing,
We've had the ability now to scorecard practices too. We can show a practice how many potential patients they have going forward that are on the brink of dialysis through AI or other mechanisms. And Dr. X has 4 patients on the brink in the next 12 months. This is an opportunity to put 4 fistulas in, have 4 planned starts, and put a dollar amount on it. How much you saved and how much you got incentivized to do so. And some of our practices, the real sophisticated ones, will even go into shared savings and risk models with us at Monogram, independent of their insurance relationships or fee-for-service contracts.
Oh. George, what are you guys doing over there with the?
So remember, 1,800 nephrologists, 1,200 actually invested in Interwell, so they have a level of alignment that is.
They have a buy-in. They have a buy-in, right?
Yeah, that's right. But I think similar to what you're hearing from Shami and Virginia, we also have incentive programs that are related to, and tend to align with clinical metrics, whether it be optimal starts, whether it be, other metrics. We are very much dedicated to sharing savings with our nephrology partners. And I think if we want to talk about something that's changed over the past 4 years, I think it's the nephrology practice appetite to participate in shared savings, understanding that there's some downside risk.
And are they okay? I mean, how are these practices kind of shielding themselves from that risk, or how are you guys helping them with that? Is it just better navigation of the patient? Is that what you're doing, or?
Well, I mean, again, remember, nephrology practices really aren't set up to participate in value-based care in the sense of they can't put in the upfront dollar to make the commitments. So, there's actuarial support, there's data support. Through Acumen, we have the ability to, again, step back and do population management at the same time that they're doing individual management.
Oh, wow.
So we can identify patient populations that are nearing end stage. We too can track their stage 4 and 5 patients. We give them scorecards on optimal starts and other metrics. So that kind of constant feedback helps them hone their skills, so to speak.
Yeah.
And also, we also have created some incentive plans through Acumen that we think, address some of the challenges in value-based care, which is that if you participate in shared savings, the reward is 2 or 3 years down the road. So trying to come up with things that are a little more proximate to what you're doing is another way of creating some incentives.
Okay, good. And so let's go over some of the metrics that we have, guys, out there. If you have questions, please put them in the comment section. I'm waiting for the ask. Probably within 10 minutes, we'll start asking them. But I went over some key metrics, but I wanted to know how are you guys implementing them? What any results you've seen? So optimal starts. What are you guys seeing with that? How are you implementing those best?
You want to go?
Shami, go ahead. Shami, go.
Yeah, sure. I can start. That's one of our key metrics. We want to increase the rate of optimal starts. When we go to a market and start working with practices over time, we see that number go up. And we're trying to even avoid anything from the hospital, whether it's ideally not a CVC, but even a CVC outpatient start is better than a hospital-based start.
100%.
So we try to identify these patients that are at risk and do those things. So we'll see a 10, 15% uptick once we're in a market for some time. But our biggest value is removing CVCs and those sorts of things. So we're seeing a lot of less CVC time because we think that's very important to driving better outcomes. And we're able to actually even put dollar amounts on how much savings is created for each one of these individual events. A CVC removal might save $700, $800 a month, PM, due to decreased sepsis and other related costs associated with that. And you share that with a practice. And then to George's point, shared savings, and all of a sudden that's real money, real dollars that are floating around that are out there if you get that catheter out because you don't cause sepsis. So, we've seen a decreased hospitalization rate along with somewhere increased home dialysis utilization, although that takes time to show those results. You can't just go to market and show increased PD in 3 months.
And we're going to get to we're going to get to that, Shami. So let's go to the optimal starts with the other guys real quick. Yeah. George, what you got? Any insight into that? What you guys are doing? How are you guys implementing that?
Yeah. So remember, in the CMMI models, optimal starts are one of the quality metrics that has a significant impact on a withhold. So a lot of effort, a lot of energy, and we've been able to move the needle. Unfortunately, as we're doing this here tonight, the results from the first year are not yet public. So I can't really get into specifics, but we're very excited where we're landing from our own internal analysis and believe that, we've been able to significantly move the needle in optimal starts.
Great. Virginia, I know you guys are kind of involved in that too, right?
We are. So the metrics that my team reports on every month are the same metrics that all the value-based care organizations are looking at. When I started with the organization, they were still referring it to as the crash rate. Day one, I said, we're not calling it the crash rate anymore. We're calling it the optimal start rate. And, and along the same line, I said to the ChenMed nurses, let's tell patients we want to optimize their care. We want to optimize their entry into dialysis. Don't tell them they're doing something wrong and they crashed. Let's change the messaging to patients. And, it's slow and steady. My feeling is it takes decades to get to ESRD. It shouldn't be a surprise. 80% of the time, we should know that patient's going to progress at some point and we should have a plan. So really working with the education piece as soon as that GFR is hitting 20 and making sure that there's a plan in place, getting the access in place, getting the patient listed for transplant, and working with the nephrology team to really move that patient in the right direction. It's a challenge in some markets. Again, many of the patients I deal with are in areas where there's true social determinants that are issues, housing issues, food insecurity, a lot of that, and it makes that optimal start a real challenge, but it doesn't mean we can't achieve it.
So how important is having a dialysis access center, like a vascular center available? I'm saying this as a bias because I'm an interventionalist. So I remember that I remember seeing the benefit of having a vascular access center to your practice. So how do you guys partner with people? Do you guys help, you guys help them build or suggest they build their own vascular center or something like that?
From our standpoint, I will tell you, from where I was in South Jersey, I could get an access done in a second. It would not have ever been a question. I see variability across the entire country, as I'm in 15 different states, that's not the case everywhere. Just getting a vascular surgeon in some areas is hard. So it really is state by state, region by region, significant variability. It should be easier than it is.
Yeah, we try to build it out as we go into markets. Same issue Virginia brought up. In rural markets, there's just not a lot of, no pun intended, access, to these folks who can do it. And so we have to have a long lead time, early identification, who's going to progress. Someone's getting hospitalized all the time, they're more likely to progress or crash. Let's focus on that population first and try to get them to the place they need to be to get those things done. And then, of course, emphasizing, non-fistula based dialysis, PD, and other things, even in not the ideal patient, may be better for them in rural markets in particular, where they have a hard time getting to dialysis centers.
And that's a big thing. I trained in Louisiana myself, and I remember driving an hour to a dialysis unit to do rounds. It's far away.
Yeah.
And so but to me, what's interesting is with those vascular access centers, there's some cost savings that a lot of people don't realize. Like, for instance, like Friday, I was always hit with like 3 thrombectomies, right? And I'd open those fistulas. Guess what? I just saved 3 hospital admissions, right? Yeah. Like, never got rewarded for it. I mean, I got paid for it, obviously. But, those kind of things, those little subtle things that a vascular center can do, that, or even that reassurance to implement, cannulate the fistula, which sometimes a fistula sits there.
I think one of the things that's happening now, and where I was practicing in Charlotte for a long time, this is happening, is if you have enough patient volume and you have an access center and you have a good relationship with surgeons, we're starting to see access creation in access centers, particularly those that are ASCs. So now you're looking at a significant cost savings compared to doing it in hospital.
Oh, yeah.
So I think that's a motivator. Certainly the percutaneous interventions and the ability to put in Tinkoff catheters in an ASC setting is important. One of the sister companies to Interwell is Azura, which has 70, 75 access centers across the country. And we're having conversations with them about, how do we better partner in ways to improve Tinkoff placement, fistula education, and how to improve overall surgical commitment. Because let's face it, the reimbursement for a surgeon is not very good, and trying to even include them in certain markets in value-based care in the future is the direction we're hoping.
Yeah, it's amazing to me that the access creation is not reimbursed as well as the angioplasty. It's kind of weird. It's kind of weird if you think about it. I was the plumber afterwards, but I got the
It's a world gone mad.
Architect. But that was one of the interesting things I thought was, with the vascular access center being at the heart of your program, that helps with optimal starts. That helps with, getting that access. And even later, like a lot of times we talk about GFR of less than 30 and get that access in. But like to Virginia's point, if you have an access center at the ready, you can wait till like 20, wait till they decide we really need to actually implement it. So to that point, home dialysis penetration. So what are you guys doing for it? Are you guys trying to think about more PD, home HD? What are you guys thinking about right now? And what results, some of the results you've seen?
I'm happy to start. So we're a home dialysis first company. I'm a firm believer in home dialysis, and going into the home with our teams allows us to identify not the ideal patient, but what barriers to remove patients. So we engage with nephrologists all the time around this patient's in center. We think they can do home. They have a spouse that's supportive. We're going in the home every month or 2 months or 3 months to help them, or more often. So creating more, increasing the denominator is one of the things we focus on at Monogram to increase that home dialysis rate. We're getting new patients into our protocols all the time. So we've been able to maintain a pretty healthy rate in the high teens across our book of business for those patients on dialysis. And we think as we stay in the market longer and longer, we get better and better at it. So yeah, we've seen a lot of green shoots and a lot of positive energy around patients wanting to do home dialysis, but they need the right support and the right.
I think you have to. The thing is, Johnny, I think you have to sell it as a nephrologist.
Oh,
I think for the longest time we just said, "Do you want to do it at home?" You want to do it at home.
And I always joke around. In Louisiana, the best time to sell a generator, is in the summer. So when the power's out. So when someone crashes into dialysis, their fistula is not working, and they have a CVC they hate. That's a good time to talk about PD. Okay, so we don't just talk about it once. We talk about it at the beginning, and we revisit it at these crucial moments when a patient is more open to doing it, or having them interact. We have a peer network of patients that are doing PD that can engage with our prospective patients, talk about their patient experience on PD, because the doctor can tell you one thing, but another patient telling you, your peer telling you is a different thing. So we're trying to think of innovative things like that, where our own internal PD patient population can engage with other patients and help educate them on their optionality and what it means, because they were in their same shoes before. So there's some few things we're doing, but we're seeing consistent rates, across our book, despite new patient entry, which we think is a good sign, and we hope to keep that number going up to the goals you described in the first entry of your introductions.
Yeah. Hey, George, go for it.
Yeah. The way that we think about this is let's go back to the optimal start metric, because I think if you are achieving optimal starts, you're doing a lot of things right in terms of how you're managing your CKD population. You are appropriately educating them on their disease state. You're taking the time in advance to give them an real understanding of what their options are going to be, what the modality choices can be. Because what we really want to do is find the right fit for an individual patient. We don't want to start a patient on home just to start a patient on home and achieve a metric. What we really want is that patient to last on home, because the consequences of failing at home sometimes can be catastrophic. So the appropriate selection of patients matters. Just like it matters with transplant. So trying to give patients in a easy way, in a proactive way, the chance to really digest all of their options, be able to address what are the equity issues that might be going on at home. Do they have power? Do they live in a tiny apartment? And those type of things that might impact their ability to be successful at home. All that's important.
Well, we're seeing. Also, to your point, what you're saying right now, Alex Barrios, your patient advocate with Interwell, he said he would have loved to have a peer-to-peer discussion, but on a previous Disrupting Kidney Care, he brought up it was just too difficult to do PD for him, the timing and everything else. So sometimes life gets in the way,
PD can become a full-time job.
Yeah.
Depending on it. So
depending on how it's going, yeah.
Yeah. So, do you have a partner? Do you not have a partner? All of these things factor in. But we're seeing success. And I think we're seeing a rise in home therapy rates.
Are you guys seeing anything like from the in-center going to home HD? Are you seeing that kind of trend at all or much? Oh, go ahead.
I think you see a lot of success when you have transitional care units.
TCUs, yeah, absolutely.
Yeah.
And just given that thing, Virginia, tell us what you guys are doing. Are you guys getting involved in modality choices of modality as ChenMed as well too?
If you said to me, what are you most proud of for your first year at ChenMed, it would be the growth of our home program.
Wow.
When I first started, one of my first meetings with the ChenK nurses, I was very enthusiastic and shared, we're going to grow home. And the one ChenK nurse who I think is probably on this call watching says, yeah, not in my market, you're not. We don't really have a lot of that. And I'm like, you're all going to believe we're going to do this. And by the end of the year, I had markets in the country who had never had a PD patient. All of them had PD patients.
That's
and
awesome.
It's just making everybody believe that they can do home. It's being the cheerleader for the patient. And it's also, now I have primary care doctors who are reaching out to me saying, why isn't the ChenK nurse identifying this patient as a PD patient? Because I think that patient can do PD. So it's educating the whole team, and it's educating the primary care provider. Everybody needs to be a support for it to be a success.
Wow. And what's interesting is as I do, because I'm big on home now too, I'm having lesser and lesser dialysis accesses in my CKD4s because I'm wanting them to do PD. And so I think what we brought up before, different markets have different trends, but I've seen I did some work in Arkansas. They have the PD catheters tucked away. You know what I'm saying? Where you can just literally just make an incision and pull them out. Whereas where I'm practicing, I have to put the PD in catheter when they're ready to initiate. You see what I'm saying? Yeah. So even something as simple as that could help augment peritoneal dialysis a little bit more, you know? But yeah, the in-center experience, I mean, I'm a big fan of the TCUs. I just think it's a great idea just to kind of slowly introduce them, because I think there's a lot of fear of it, doing it at home. Let's see here. Let's go over this. Conservative management, no dialysis options. So Shami, I know you guys are big on that conservative aspect, and I fundamentally agree with it in many respects. Sometimes we put people on dialysis we really don't need to. And so what are you guys doing with that exactly?
Yeah, so we apply criteria. You know, again, they're broad-based criteria that I think we would all agree upon. You know, elderly, frail, mentally challenged or incompetent or struggling with Alzheimer's, those sorts of things, and the lack of support. And those patients probably won't thrive well on dialysis. So, you know, we're living at a time now where there's a lot of medicines out there that can extend life, you know, potassium-lowering drugs and optimizing diuretics, and really being there for the patient. Again, just to go back to our in-home model, that patient would end up in our palliative care pathway, working with the PCP. Monogram can provide the palliative care to that patient with the PCP. We can utilize resources within the health plan that they're in their networks. But the point is that patient's educated about that option too: transplant, dialysis, and conservative kidney management. So we feel that all three are viable options for the patient in the ESKD pathway.
And you know what I think is so crucial, Shami, is to actually have advanced directives in place, you know, like, and DNRs and all that kind of stuff.
For all patients, not just
all patients. Yes. Like, yeah, I don't understand why we don't have all patients.
Even the patient on dialysis pathways need that.
Yeah.
And I couldn't agree with you more. And just to go a little back to your other question about the incentives again, you know, nephrologists are the leaders of these patients, right? They're the ones managing the care. The PCPs feel uncomfortable often with this level of illness, and they're not really rewarded for taking care of these patients, which take an inordinate amount of time. So, you know, overlaying some small incentives to keep that physician rewarded for their this intervention they're doing is important.
Because that's not an easy conversation. I mean, that's not an easy conversation to say, hey, no dialysis. It's okay if you die.
But planting the seed early, so it's not an abrupt thing. Like if you don't do it, you're going to not, you know, plant that seed early. And CKD4, like you mentioned, if you have that.
Yeah, that 75-year-old CKD, ESR, GFR of 20, start having that discussion. But to me, getting it on paper is so crucial.
But I do think, you know, if we're engaging with a nephrologist in the community who has a different opinion, they know that patient better, they think they're going to be a good dialysis candidate, they have a long lifespan on dialysis, then back to the earlier metrics, get a fistula put in or a PD catheter and optimize start and run with it. So it's not but it's just broad-based guidelines we apply to the patients we manage, because we're taking risk on them and want to make sure that their physicians have the support they need to make those right decisions for them.
And George, is that something you guys are doing at Interwell as well too? Kind of.
Yeah, I think the way we approach this and think about it is that patients need to understand all of their options. And one option is going to be to choose a conservative pathway and a non-dialysis pathway. And we want to make sure that patients feel comfortable and empowered to make that kind of decision and to have some, say over how their life plays out with kidney disease. We do that in conjunction with the nephrologist, but the reality is that many nephrologists are uncomfortable having these conversations. Mm-hmm. Turns out nurses, social workers, sometimes the dietitian is the right person to break down the wall and get the conversation started. So our social workers and our nursing staff are very attuned to make sure that these types of conversations can happen.
That's awesome.
Advanced care planning is frequently a metric that payers want to put in as a quality metric. So we are addressing that on a regular basis. The other thing is that in the KCEs and the CKCC programs now, there's some exceptions for hospice, where we can do hospice care and continue dialysis for a limited amount of time. So I think that's an attractive option for some patients who kind of aren't ready to completely.
Like a palliative dialysis, I would say? Or is that what you're saying?
Like kind of... For with bumpers around it, and that program is just getting started now. So
I've heard that kind of thing, like with PD, like George, like, just doing like a few exchanges a day, like an exchange or two a day, just to keep the person happy and around, and not give them the full treatment and go after a KT over V for no reason, kind of thing. Virginia, like you guys are clearly the PCP, so you're probably, educating them on like that kind of stuff. So go for
it.
it.
We have contracts with, palliative care and hospice organizations, and it's easy to, engage in the patients with the primary care provider and to move in that direction. Often it's also, because of the model that we're in, it's the primary care provider, the cardiologist, because we do have in-house cardiology, myself, all looking at cases together and realistically saying, what is the right option for this patient? If they're end-stage cardiomyopathy and there's no blood pressure, nothing I can do to help that patient. Let's have the proper discussion and move the patient in the right direction.
Yeah, Qasim, I'll just add, we have centrally based palliative care physicians at Monogram who can support the PCP as well. So if that PCP feels it's a non-dilated candidate, to Virginia's point, they don't even need a nephrologist. They can go right to a palliative care support model. Or if that patient needs education by a physician or a palliative care educated nurse, we can deploy that to kind of grease the wheel until they get to, another provider, or we continue care. Yeah.
And the thing that I think is important, you guys have a lot of integrated health and, different providers and, case managers and everything. I think it's important for the team to be on the same message. So if this is a palliative care message, we should all focus in on that PD. Because I've had people do contrary, why would you do PD? You should do this, when I said do this, you know what I'm saying? So I think that consistency and messaging is so important from the organization. The one I really wanted to get to, and I think is really important, decreasing CKD progression, right? Decreasing it. What meds are you guys optimizing? Are you guys trying to implement those kind of things, those routines as well?
I'll start with that. So yes, use of SGLT2s are crucial. I will say that there's times that I have to talk to some of the nephrologists in the market. Kerendia is $680 for a 30-day supply versus $22 for spironolactone. And if I don't want the patient to be in the donut hole in the first 2 months, and I want them to be able to be on the SGLT2 and spironolactone for a year, we have to think logically about some of these medications that we're ordering.
And just so everyone's in the audience to know, the three meds that are kind of not hot, but the prevent CKD progressions are ACEs and ARBs, ACE inhibitors and ARBs, SGL2s, which are new to the market as well too over the last few years. And the new one is Finerone, which is Kerendia. And so those are the three to do out there. So George, what are you guys doing out there?
Well, the truth is that so many of these drugs are not being implemented in the ways that we would think. When you look at A2 blockade or ACE inhibitors, we are 25 years into some of these drugs, and the broad application of these drugs in the CKD world still falls short of where we think it should be. So there's plenty of opportunity to leverage, existing drugs while we're trying to figure out what is the role for SGLT2s, how are they going to be paid for, and what is, Virginia, to your earlier point, CKD patients stay in their CKD stages for years. And, what's the willingness of a payer to invest in this if patients are rotating in and out of these programs on an annual basis or every 2 years?
Yeah, we deploy our own pharmacy, Qasim, to evaluate the medications the patient's taking. In-home models sees what they're actually taking.
Oh yeah,
maybe they have a medicine that they're just not taking it right, or don't understand how to do it. So we go in the home and kind of optimize that first. DC nephrotoxins, obviously, but I would echo what Virginia and George said. It's deploying the right medicine to the right patient. And we have the ability to connect with the payer also and kind of have their ear on a lot of these things about this medicine does show a decreased cost, or there's an ROI on this medicine for a certain patient. Not every patient, right? But which patient is going to progress, and how do you analytically decide which one that's going to be? Someone with proteinuria, someone with a decrease in X% over X time. How do you target
that trend? Is really important, right? To see that trend, of that graph.
Yeah, many people stay in the same stage forever, they don't progress, or they pass from something else, right? And why would you want to? So how do you know who's going to end up benefit the most from that? But I couldn't agree more with what George said. Optimizing what we have already is probably plan number one, and making sure people are taking those first.
And I've seen that too. So for my own clinical practice, my goal is 2 agents, right? ACE or ARB, and then maybe an SGL2, and then maybe Finerone if one of those doesn't work. But I've seen some docs literally putting all 3. And I'm like, and it's I almost want to say it kind of contributes to polypharmacy sometimes, right? Yeah. When you have so many drugs on board to go after something that may not be worth it in the long run, So, but yeah, let's see here. big question someone asked. Let me see here. Going after this, and this kind of let's see here. Who was there? Someone asked about artificial intelligence and how you guys are utilizing artificial intelligence. Can anyone comment to that?
So again, having a very large population of chronic kidney disease patients, 50,000 patients in stage 3. As we were just discussing with the medications, I can't give everybody SGLT2s or everybody Finerone or an MRA. So we are starting to utilize AI to start understanding populations of patients and really who's going to progress. 2 out of 100 will progress to ESRD. So how do I identify the 2? Like, do I give all 100 patients all the expensive meds? No. And you need AI to really be able to identify those populations.
The at-risk ones. Yeah, absolutely.
For us, similarly, evolving data, seeing our experiences. Obviously someone who's going to the hospital all the time is probably more likely to crash than somebody else. Gross and crude metrics, but then really getting the nitty-gritty of what A1C is dangerous, what proteinuria level is dangerous, and how do we deploy our resources and see those patients. So it's evolving, but getting better. But I still think it's got a long way to go for us to apply.
I think the identification of patients is the crucial part, right? That sometimes we just can't look at the entire patient chart, right, to know what's going on. And that's George, go for it.
Well, I mean, look, let's face it. AI is a nice, bright, shiny object, and we're all chasing it right now, and are trying to find what we think, ways that we can use it. It's kind of exciting and terrifying at times on how we're going to use it. I think the ways that you guys are talking about and how we're going to be smarter in how we apply some of these drugs and other therapies in CKD is a really important use case, and predicting high risk progression is going to be important. But there are other ways that AI can be very helpful. We're looking at how can it help in documentation for a physician, so that if a physician has a 20-minute visit, today they have 5 or 8 minutes with a patient, the other 12 to 15 minutes is in the EHR. How about if we can cut that down to only 3 to 5 minutes?
Yeah.
So now we've returned the doctor back to the bedside, back to the patient. The patient journey is going to be better. They're going to feel better about their visit with the doctor. The doctor might actually do a better job of picking up things and taking time to be able to have appropriate conversations. So I think there's a real powerful opportunity there. And one of the ways we're trying to do that is with Epic and Acumen, and taking AI so that we can help work to cut down that amount of time that we're all spending in an EHR.
And I think that's like the key there. I think it's the low-hanging fruit of medicine that can really be beneficial to us. Like, it's not like the fancy stuff. It's like the scheduling, the insurance approval, the note-taking, all that stuff that consumes our time but doesn't add value, right, necessarily. So I think that could be a good application of it as well. Alex Barrios did ask about patient education. What you guys are doing for patient education for these people?
So we do. The ChenMed nurses have a platform of education that they utilize. And again, similar to how all the value-based care organizations are doing it, treatment option education, diet education, medication education, all the different steps along the way. But I think the most critical is really making sure that treatment option education is clear, concise, answers questions, and that the patient has the ability to come back with family or themselves to continue that conversation later on.
Yeah, I think we focus everything Virginia said, but also education of the other constituents in the home, family members who are affected by this illness, and how it impacts them and how they can help and support their loved one in this journey is crucial, particularly with STOH and behavioral health type issues that may accompany this very complicated illness these patients are dealing with.
You know what I started to do is like actually have them bring, like when they're CKD4, I start having them bring their family members in, so you can have the talk. Like you just have to have them physically all there, understand what's going on and the severity of the situation. Because I think like when you when that patient tries to go back home and translate that message, it just doesn't. They never get it.
I'm fine. It's I'm fine. The doctor said I was fine. Next time.
Yeah. That's the husband answer. That's always the husband answer, right? So, George.
I mean, look, this is all about how do you pick the right patient, deliver the right message at the right time, in the right place, in the right way.
Yeah.
Some patients want an app. They want digital communication. Other patients want a telephone call. Some patients need face-to-face. We've created a video system for education in both English and Spanish.
That's good.
And the other piece is that you have to realize that sometimes you have to have these conversations, not once, not twice, but 3 or 4 times,
multiple times, yeah,
until you hit the right moment. So that's
and
how
to
we're
your
going.
point, like, I think it's like, in what point in their life are they ready to receive the education?
That's right.
You see what I'm saying? So I don't think, like, you can educate me about a topic I don't care about, and I'm not going to listen.
Well, you have to throw them a pass they can catch.
Yeah. 100%. Yeah. Great analogy. So
you introduced me as a 6'6" Michael Jordan. So
yeah. That was a great one. Yeah. Well, you just dunked it, sir. You just dunked it. Okay. So, all right. Final question. How do you define success, and where do you see value-based care in 5 to 10 years? Virginia, I'll start with you.
I would say for my organization, success is decreasing hospitalizations and rehospitalizations in this patient population, even over the optimization, because again, the cost of care and the downside of risk, it really, hospitalization, rehospitalization is crucial. We have been successful in bringing down our admission, readmission rates, by working with some of the LDOs and doing shared care, or shared risk, I should say, where we communicate weekly back and forth, the patient's most likely at risk to be hospitalized, and how can we make a difference? How can you make a difference? And we have shown success in that. So I would say organizationally, that's probably the biggest,
Virginia, to your point about what you guys do, like, we had worked my own practice with a primary care group here that was value-based before I even knew what value-based care was. And I say them having an urgent care center was so crucial to them preventing hospitalizations. You see what I'm saying? All those high potassiums they used to send directly to the ER, they were like, send to our urgent care. If they're short of breath, send to urgent care. So they were able to handle it. So I can see how a ChenMed could be able to offset that hospitalization by just having those resources available. George, go for it. How are you defining success, sir? I know you have 6 rings, right? You have 6 rings. So
yeah, that's right. I mean, look, there's a lot of stakeholders here, and a lot of people looking at us in all different directions. As physicians and CMOs, I think we should focus on the patient journey. And if we are keeping people out of the hospital, good things are going to follow to all of the stakeholders, and all interests are aligned. I think the other piece of this, though, is we have to remember that CKD is a personal journey for the patient and their family. And how do we honor that and stay close to it, and realize that, at Interwell, at least, we have 125,000 personal journeys that we need to try and preserve, yet be able to step back and handle this on a population level. So our focus is to try and reduce hospitalizations, make sure that we capture the complexity of patients through proper risk adjustment. And if we can do that, then, we are helping the patient, helping our payer partners, and our physician partners.
Yeah.
Shall we go for it?
That's easy. After going over those two, that's easy. I'll echo what my colleagues have said. But I really think recognition that CKD is a polychronic illness. It's not a siloed illness. It often is accompanied by other chronic conditions, and attacking all of those is important to taking care of these patients that are ill. And I'll quote my colleague from Balboa Nephrology, Vigil. He said he dreams of a day when it's called care, not value-based care. So it's just care. We take care of all the patients the best way possible. And he told me that one time at a conference.
No, I think it was one on the podcast. Yeah, when we had
I love that quote he gave, and I think that really resonates here. One day this will just be care. We take care of the patients the best way possible.
In 5 to 10 years, are we going to have fee for service much? Or are we going to have essentially a value-based healthcare system?
Yes.
Yes. Everyone MA, everyone kind of in that part. Yeah, I think they're going to get. What was it, by 2030? They want to get rid of it right, or something like that. Is that right? Like
95% of ESRD will be, Medicare Advantage by 2030.
And I think surgical procedures will probably all be like a bundled kind of payment in those kind of schemes, right? I imagine, right, in the future. So interesting.
Well, I mean, look, that's what CMMI is trying to do right now. They're trying to figure out, is the current model the right model? What are the tweaks they need to do? And are they going to certify it as the standard of reimbursement across the country for Medicare patients? And we got several years left before that decision may be rendered.
Interesting. Final thoughts? We're about to cut off. So Virginia, go for it. Any final thoughts?
No, thanks for having me, and really enjoyed the whole panel discussion with my colleagues here. Thank you again. Blessed to be in this ChenMed position and serving primary care providers to provide the best care to CKD and ESRD patients across the country.
George, go for it.
Look, I think the three of us that are on this call tonight are fortunate. We are, as they say in Hamilton, get to be in the room where it happens and get to be a part of conversations and that I never dreamed we would get to be a part of. So this is a fun time. And I think history will look back on this and see it as a real pivotal time in healthcare and certainly in renal healthcare.
Yeah, just again, thanks, Qasim, for hosting this. I think it's important you get the word out and convene folks like ourselves to share our thoughts. And I had a great time meeting George and Virginia on this call. And again, I look forward to seeing where we're going to go. I think the sky's the limit with this, and it's really patient-centered. It's payer-centered, patient-centered, and outcome-centered. It's really got the trifecta. So excited to see where it goes. So
awesome, guys. Well, hey, thank you all for being here, and everyone, I appreciate y'all being here. And if anyone wants, let people know they can still watch this later. It's live, but it can be watched later as well. Okay. Have a wonderful day. And remember, it's your kidneys, your health.
Okay. Thank you.
Bye, guys.
Good night. Thanks.